From training to performing, join our big league conversation. Welcome to the CSP Elite Baseball Development Podcast with your host, Eric Cressey.
Welcome back to the CSP Elite Baseball Development Podcast. I'm your host, Eric Cressey, and this is episode 89. We're continuing with our sports medicine themed run here, and I've actually got one of the really bright orthopedic surgeons that specializes in the baseball community, someone who's really been at the forefront of diagnosing and treating lat and teres major injuries in pitchers. So he's a guy who's had a really prominent role in the advancement of sports medicine in the baseball community. Selfishly, I booked this podcast because I had a lot of things I wanted to learn and questions that I wanted answered. But more importantly, for a larger audience, this is going to be some really great info. I learned a ton, and I'm sure you will too. If you're a baseball pitcher, you know that keeping your arm healthy is essential. But with high training volumes on top of participation in games, that's not always easy. Overuse is a significant problem for players at every level of competition right now. Certainly, we see elbow and shoulder injuries as some of the most common overuse injuries in baseball. At the professional level, an ulnar collateral ligament of the elbow injury can result in an average of 17.2 months out of competition. For youth players, overuse is also a predominant mechanism of injury. If you miss out on that much time, you're also missing out on a lot of development. So really, at the end of the day, there are three ways we can combat overuse. First, you can reduce workload, and certainly there have been a lot of research studies out there on pitch counts. Second, and the theme of this podcast, is that you can build a significant level of fitness to prepare yourself. However, a third key approach that's often overlooked is that you can work to improve your recovery so that you can safely display the fitness that you've built day in and day out. And that's really where MarkPro is an effective tool. Some athletes will even use it to warm up their arms before they throw. MarkPro is a cutting-edge EMS device that uses patented technology to create non-fatiguing muscle activation. And this is what sets it apart from other recovery tools. Muscle activation with MarkPro facilitates each stage of the body's natural recovery process, similar to active recovery, but without the extra effort and muscular fatigue. Athletes can use it for as long as they need to ensure a more full and quick recovery between training or games. With its portability and ease of use, players can use MarkPro while traveling between games or while relaxing at home. We even have players that use it all the time on team flights to help them bounce back. We have plenty of pro athletes that use this, and players from every Major League Baseball team use it. Put MarkPro to the test for yourself and take advantage of the great deal they have set up for our listeners through the end of May. Just head to markpro.com and use promo code Cressey at checkout for 20% off your order. Again, that's markpro.com, markpro.com, and use the promo code Cressey, Cressey, at checkout to get 20% off your order through the end of May. Today's guest is one of the nation's leading orthopedic surgeons, specializing in the management and surgical treatment of shoulder and elbow conditions. He completed his Bachelor of Science degree at the University of Notre Dame, where he was also a varsity football player. He then earned his medical degree from the St. Louis University School of Medicine, and then completed a residency in orthopedic surgeon at the Cleveland Clinic Foundation. He then did his shoulder and elbow surgery fellowship at the University of Washington Medical Center in Seattle. He spent 25 years practicing in Chicago, where he served as the team physician to the Chicago White Sox and the Chicago Bulls, as well as a consultant for numerous NFL, NCAA, and Olympic-level athletes for more than 15 years. In 2018, he moved to New York City to serve as the chief of orthopedics for the Rothman Orthopedic Institute in New York. His work included being on staff at Lenox Hill Hospital, as well as a full professorship in the Department of Orthopedics at the Zucker School of Medicine at Hofstra Northwell Health. He recently returned to Chicago, where he continues to provide care as the Executive Vice President of the Musculoskeletal Institute for DuPage Medical Group. Over the course of his career, he's developed innovative shoulder replacement systems for the treatment of arthritis and rotator cuff deficient shoulders. He's also been involved in the development of techniques, instruments, and implants to treat unstable shoulders, as well as those with rotator cuff tears. He has numerous patents related to the devices and techniques that he's developed to improve the care of patients with orthopedic conditions. In addition to teaching courses to the next generation of orthopedic surgeons, he's a prolific medical researcher, publishing more than 400 peer-reviewed journal articles and 30 chapters in medical textbooks. Specific to today's podcast, he's authored or co-authored more than 50 papers on baseball injuries alone. Please welcome to the show, Dr. Anthony Romeo. Thanks so much for joining us, Dr. Romeo. Welcome to the show.
Eric, thank you very much for having me.
I'm extremely excited. Obviously, I've I'm familiar with your work, and certainly have delved in on this topic quite a bit myself in maybe the less clinical realm. But I'm really intrigued to kind of put our heads together and brainstorm on some of this stuff. So I'm excited to get your clinical expertise in this realm. So I know you're prepared in a variety of orthopedic realms, and but with that said, you've definitely over the last probably 10 to 15 years become the most well regarded as a specialist in the area of latissimus dorsi injuries, which are certainly on the rise in baseball at all levels. I'm curious, could you tell the story about how you kind of wound up in this particular area of specialization?
I certainly can. It was a remarkable story, quite honestly. And it was a game on an evening that I was actually not covering the White Sox. And he's given me permission to use his name. So I'll go ahead and say it. But Jake Beebe was in, I believe, the third inning of his game. He was not fatigued. He felt fine. And he went to throw a pitch, and the pitch was delivered properly and got to the catcher. And he immediately reached with his left arm into his right pitching armpit and kept his arm up and just walked right off the pitcher's mound to the dugout. Didn't even stop to figure out what was going on, just walked right out. And so we all knew it was quite serious. They got back to the training room, and I got a call from one of my partners who said, Tony, I don't see this very often, but I think he hurt his latissimus. That's where most of his pain is at. And I said, well, it does happen, but it's uncommon. We had just started seeing these things, and that was in 2010. We'd seen them before, but most of them were treated without surgery. In fact, almost all the papers that had reviewed articles or reviewed series of patients, they'd all been treated without surgery, and it was remarkable how many were able to get back to sport. But you would hear from the more senior level surgeons like Dr. Andrews or others say, well, they do, but I'm not sure they really get back to the same level. Mm-hmm. In any event, with Jake, of course, the next day we got an MRI, and sure enough, he had completely torn off his latissimus tendon, and it was displaced. It was read by the radiologist, and the MRI scan showed only about 3 centimeters, which is a little over an inch. So our plan was to fix it, but Jake, of course, being from Alabama, had to get an opinion from Dr. Andrews, and flew down there. And Dr. Andrews says, yeah, you should have it fixed, but I don't do these. You need to go back and have Romeo do it. And that's what Jake did. And about a week after his surgery, which is not too long, we really would like to get to them within the first 10 to 14 days, ideally. We brought him to the operating room, and I thought it would be really easy to fix this because it was just 3 centimeters away. And I, in fact, went through a small incision in the front of his shoulder, thinking it would be right there, and it wasn't there. And I reached and I felt down. I could see that it had retracted substantially. Now it was about 6 or 7 inches away. And so I had to make a secondary incision on the side of his chest wall. And this may sound a little bit explicit, but I made the incision, and literally the tendon just popped out. It was right underneath the skin, and it was right there. So I put some stitches in it, and I passed it. I toned it back up, and we put it back into place and repaired it, and put Jake through a rehabilitation program as best as we understood. We sort of followed what we knew from rotator cuff surgery, hoping this would heal a little better because it's not right on the joint. Mm-hmm. And he did a great job with his training program. He got back the next season, and the second season back, he actually made it back to the All-Star game, did very well.
That's awesome. And you know what's really intriguing to me is, I remember hearing the initial story, and it started to kind of emerge a little bit more in the research. And a few years later, I distinctly remember a college pitcher coming in, and he had a lat repair with you. And I think he said, I'm number 17 that he's done, like this had become that much more prevalent. So I'm curious, what do you think this, why is this happening so much more? Obviously I have my perspectives on it in the, in the everyday world of baseball, but why do you think we're seeing so many more of these lat injuries? I mean, and not just in the Jake Peavies of the world, but, we're seeing them in sometimes high school kids now.
It's really, I think that there's really not that much of a mystery, because it really has a lot to do with injuries around the arm in general. Mm-hmm. And that is the ultimate pursuit of speed or velocity or velo is leading to these types of injuries. And I think the combination of the athletes that we have now that are pitching, and they truly are athletes, they're many of them are physically very strong and over 6 feet by 4 or 6 inches, and that there's a tremendous amount of torque on the arm. And as they go to throw this ball 95 miles an hour or faster, at some point they've got to decelerate that arm, and that's where the latissimus tears. And it's remarkable, if you see someone tear the ligament of their elbow, what happens, the ball just sails over the top of the catcher's and umpire's head because they can't complete the throw. But with the latissimus tear, they do actually complete the throw. The ball has left their hand, and the ball can be delivered in a proper position to the catcher, but they immediately stop because they feel a pop or something happen, and they reach for their armpit. Many times people will refer to it or think it's like in their triceps tendon where it attaches up high in the shoulder, but most commonly it's the latissimus. And I do believe it's a combination of the size of the athletes and the velocity creating so much torque that if they somehow just don't have the whole system in place to decelerate the arm, which includes the rotator cuff, it includes the latissimus and other muscles, then the latissimus may become a dominant force in trying to decelerate the arm, and it may fail at that eccentric load at the very end of the throw.
Interesting. I've often wondered just, how much, and this is a strength and conditioning coach saying this, but how much strength and conditioning has contributed to this, where we have athletes where they have, very dense, fibrotic, kind of nasty, tissue in that lat in the first place, very limited shoulder flexion, maybe not the cleanest external rotation. How much of that comes from throwing versus, do we layer more dysfunction on it when we add, lots of heavy deadlifts, lots of heavy chin-ups and things like that? Do you see that tendency in some of the guys that you're seeing who come in and have this, that they tend to be weight room rock stars? Or is it, you're also seeing it these slender build, athletes who might not have as much strength and conditioning experience?
Eric, it's a great point. And I think that what we're seeing is that many of these athletes are training for strength, but they're not necessarily training for bulk. In other words, they are getting stronger and they are doing things that are more explosive, but they're not filling out these muscles and looking like a football player or someone who's trying to compete in a contest. And so they are getting stronger, and I think that does play a role. What's been interesting and somewhat anecdotal is that we've had a few very well-known players who have put on 10 to 15 pounds of what is perceived to be muscle over 18 to 24 months, and then all of a sudden develop a lat injury. In other words, they're individuals who have decided to really dedicate themselves to a strength and conditioning program, and they have, for lack of a better word, bulked up. You know better than anybody, there's ways to train where you can get stronger, not necessarily put on so much thickness, but they've seemed to bulk up, go from 210 to 225, and all of a sudden, boom, they have a lat injury. And so I think there's some suspicion that, again, the strengthening and the ability to generate such an explosive force with our muscles has increased because of the training, because of the need to throw faster, and the latissimus latissimus tears can be a consequence of that type of effort.
And certainly in cases like PVs, it's probably a very frank diagnosis, and I'm sure there are times when it's easily palpable, even independent of an MRI. But I guess in many cases, diagnosis isn't that easy, and this is often a diagnosis that's missed. With a lot of orthopedic specialists who may not see lat injuries on a regular basis if they don't interact with a lot of throwers. What are the challenges that clinicians are facing with respect to diagnosing latissimus injuries?
It's really can be very challenging because it's not an area that we routinely are examining, although that has changed, as you've already mentioned. It was interesting, Dr. Brandon Erickson and I looked at the Major League Baseball data. We were trying to figure out the incidence of this. So we remarkably in the HITS database, the health injury tracking system that Major League Baseball has established, we found in less than 10 years over 300 athletes that were listed as having a latissimus or teres major strain, teres major being right next to it. However, when we tried to do a more sophisticated analysis and look at MRIs, we could only find about 100 patients who had, or athletes that had the actual MRI to show or prove it. So we're not sure how many of the others had it, but just were treated non-operatively. The point being is that it is a difficult diagnosis, and we're not sure, but it happens more often than I think many people actually recognize. And when you hear someone say, well, I think they might have a triceps tendonitis or triceps strain, I first think, I bet it's a latissimus problem that's really affecting them, especially if it's the posterior wall of their axilla or armpit. So I think that the key things are, number one, is to be suspicious of that whenever they hurt towards the back of their shoulder, but down lower in the armpit area. And also it does go into the actual humerus itself, but it goes up and underneath into the arm, just on the inside of the biceps. And they can be very sensitive, very sore there. As you said, when they completely off, you can actually feel or palpate the edge of that because the muscle will bunch up and you can feel the tendon. But we see many of these where it's a strain, where on the MRI we would see fluid around the tendon, but little or no signal that the tendons have been pulled off, or a type 2 where there is actually part of the tendons pulled off, but not completely. And so when you palpate that area or feel for it, it actually feels relatively normal. They're just very sensitive. And that's because you can tear 3/4 or more of that and it doesn't change the shape. And so it's not so easy to see. And we use some provocative tests. We have the athletes raise their arms up and then try to do a pull down, essentially, like you would in the weight room, and see if that aggravates or bothers them. And it's important, if you do that, you have them pull down, but also internally rotate. And you know how you, especially with your skill set, how you can isolate out that latissimus by not only bringing it down, but bringing it down just a little bit lower so you get that little internal rotation at the end. And that really brings it out. And the athletes don't like that at all when they've had a strain to their lat. Even a type 3 where it's just a couple of centimeters off can be challenging, but usually those will be very sensitive. And with a day or two, they'll have a bruising or ecchymosis in the area. And the 4s are when it's completely off. And those you can usually see once they happen, like with Jake. We just knew it was completely off, and you could actually feel the difference in the two sides, even in the training room right after the injury.
Mm-hmm. I'm curious, there's kind of two questions that spin off of that. The first one is, are those cases when you see kind of these partial avulsions the most challenging? Certainly like if you see a rotator cuff that's partially torn in a 28-year-old major league pitcher, you kind of just roll with it because it's a relatively normal finding. If you get a latissimus that has this partial avulsion from the humeral attachment, is that one of those tough situations where you're trying to figure out whether it's going to do well conservatively, or do you kind of know your odds in that situation?
That's a great question, and we've tried very hard to come up with some evidence and exactly how to understand that. And so we looked carefully at the patients that we actually treated non-operatively as well as surgically. And going through a large analysis, and again, these are primarily from the Major League Baseball, so both minor league and professional, and mostly pitchers. What we found is that the type 1s and 2s, so a strain without detachment or a type 2 where there is some detachment, it can be almost completely off. There is value in treating them non-operatively because a number of them will get back and actually do quite well and not have to have surgery. And it's very difficult to predict who those are. There are some people that have maybe a 20 to 30% tearing of the latissimus and just have trouble really delivering the ball with full acceleration because they get nervous at the end, they get a little twinge at the end when they decelerate. Whereas others, I've seen a couple of players remarkable where they had the strain, it's been diagnosed, it's not completely off, and within 2 to 4 weeks, they're throwing hard again. And it really is hard to make sense out of that. On average, those athletes typically take at least 6 weeks, but even up to 3 months. And that's been something I've been trying to help out with, because I'll get one of them sent to me saying, we've been treating it for 4 weeks, it's just not getting any better. And I'll say, well, the actual numbers show that you really shouldn't get nervous until you get closer to about 3 months. A lot of these just take time to get better, and they will. Now, what we did find is, remarkably, this is an important finding, is that when they're completely off, our ability to get them back, not just to the sport, but to the same level of performance, was better with surgery than it was with non-operative treatment. And that was a first revelation in that department, because most team physicians and physicians taking care of this had learned over the years that they don't need to be treated and they get back, but the actual follow-up data was not complete. It was only a return back to sport, but we actually looked to return back to performance using multiple data points and all sorts of sabermetrics. and found that you could actually say they returned to the same level of performance more likely with surgery if it was completely off, either a type 3, where it's off about 2 to 3 centimeters, or a type 4, where it's displaced even further than that. So because of those findings, what I recommend when they come in is that if it's partially attached or it's a type 2, then we treat them non-operatively. And there's been more and more interest in doing things such as injecting the patient's platelet so that you get a platelet-rich plasma stimulus of the healing response. This was actually based on what happened with hamstring tendons in our NFL players, and there was some benefit there. But we do treat them non-operatively. But if someone comes in with a completely displaced tendon, I tell them that the odds are more favorable for surgical repair early than they are to go with non-operative treatment. And in that setting, I believe still probably no more than a third elect to have the surgery, and most prefer to try to see what they can do without surgery. And so we end up doing a number of these late or on a chronic basis when they just can't get back.
Interesting. Now, when you see those athletes that have the like a partial injury that is managed conservatively, and they come back, if you re-image that that injury 2, 3, 4 years later, are you still seeing a noteworthy defect? Is there signal on imaging, or is it something that is like you broke your arm when you were 5 and we don't think anything more of it?
Yeah. Well, the nice thing about bone is it heals with bone.
Yeah.
And so it really can, especially when you're younger, it can basically remodel back to something that looks exactly the same and acts exactly the same. Tendons are just not the same. And what we've learned is, again, very similar to hamstring tendons, and that is you can tear 2 or you have the 3 hamstring tendons and do pretty well. And when you go back and re-image them, it looks as if the tendon actually has reconstituted itself. The latissimus does sort of the same thing. You can get a little bit of a signal change, so you don't get the really dense line of the actual tendon, because the latissimus is a very thin tendon, and right next to it is a very thick, bulky muscle, the teres major, and oftentimes the 2 will be involved, and so it can be a little confusing on the imaging. But that thick band from the latissimus can sort of reconstitute itself, and the fibrous tissue reconstitute itself. But I know from having gone back into athletes 1 year, 2 year, 5 years after the actual tear, that tissue is not normal tissue. The problem is it's actually really hard to tell where it separates from the real tissue and the basically the scar tissue when you're operating on it. But you have to be able to separate that out so you can make sure and get the tendon back to its normal length. The ones that I've operated on, they're 4 or 5 years out, are been generally high-level athletes. Some of them bodybuilders have been told there's nothing they can do, and the asymmetry bothers them, and they can't work out the same. And so we've gone back and fixed those, and remarkably, they've done very, very well. So I don't know if there's, I think probably if it's a type 4 and it's retracted way down 4, 5, 6 inches or more, that's probably going to be very difficult to get back. But if it's like type 3 and stays there and scars into place, and it just doesn't look right and it doesn't work right, we can fix those late in the game. So the answer to your question is the body does make an effort to reconstitute that tissue, but it's fibrous tissue and it's disorganized. It's not the same appearance that the God-given tendon is. A very well-aligned collagen. And so therefore it's there, it's better than nothing, but it's not the same as a normal tendon.
Interesting. And, just to backtrack a little bit on the diagnosis aspect of things, I know one of the challenges in looking at, at a lat injury is that it's an upper arm injury more than it is maybe a true shoulder injury. Can you describe maybe where folks are missing out with, traditional shoulder MRIs versus imaging closer down to the insertion? Do you see that mistake made a lot diagnostically?
Yes, I think what happens today is that now that there's a greater awareness, as you pointed out, people are pretty sure it's a latissimus tear. And then they get an MRI, and the radiologist reads possible latissimus tear, need further imaging, or because they're seeing it primarily on what we call the axial views down at the very bottom or the lowest part of the MRI scan when you put a coil on their shoulder, which is the most sophisticated way to get good imaging. And the problem is that normal gantry, or the area they're imaging, just is going to the level of the latissimus attachment at its bottom edge. You have to see the whole lat. So even if the upper part's off a little bit, it's hard to determine exactly what the injury is. So what I always suggest is essentially a protocol where we ask for a MRI of the shoulder with lateral chest wall views. And so we get the standard MRI of the shoulder, so we have that information to make sure it's not something that's more unusual that we can sometimes see, like a tear of the subscapularis or the capsule right in that area. We have seen a combination of latissimus tears and inferior capsular tears. And so these are things we can look for, and we can see that really well on a standard MRI, the capsular tear. But when you get the lateral chest wall view and it shows that muscle and profile, anyone that has a little bit of a background in the anatomy of latissimus can make the diagnosis. You don't have to be a radiologist or an orthopedic surgeon. You see that muscle go up, and all of a sudden there's a gap. And it's exactly the way you portray the muscle instead of looking at a kind of a strange angle with the axillary view. So if you're concerned about that, I would suggest you ask your radiologist to prescribe for the technician a MRI with lateral chest wall views, and you'll be able to see that in great profile and know exactly what it is.
That's awesome. Now you alluded to teres major earlier, and certainly we're seeing those now in baseball as well. Where do they belong, in this discussion? Are there anatomical differences with respect to that conjoint tendon with the lat that make each case unique to manage, or are teres all teres?
Eric, this is a question actually at some point I'm going to put back on you, is like, how do you isolate out the teres major versus the lat when you're training? Yeah. They're coming at a slightly different vector. The teres major is a little bit higher up. It wraps around the same way as latissimus does, but it inserts less than a centimeter away from the normal latissimus. So it still does the same kind of movement where it pulls the arm down against the chest wall and it internally rotates. Or the corollary is that as the arm is being decelerated, it will contract to try to hold the arm from separating from the scapula. And what we've seen is, and actually it was reported some time ago, but I think it was just kind of, not prioritized. And people said that, well, when you get these lat tears, that's really the bad thing. And every once in a while you get a teres major that's off too. But remarkably, we get isolated teres major injuries, but not in baseball typically. It has happened, but that's very uncommon. It's usually the lat and the teres major, and then maybe the teres major. But where we have seen it is sports like wakeboarding, kite surfing. So when the arm is kind of straight out in front of you and you have something that you're holding onto and you are contracting, and yet you get a force that lengthens the arm, so an eccentric load in that position, then your teres major may be the primary decelerator and may rupture. So I think the lat probably is more engaged as the arm is in a slightly higher position with regards to the scapula, and with the pitcher as they're coming over the top, the lat is a little bit more the primary, and secondarily is the teres major, but it's right there, and it can go on to tear the teres major. In fact, when people sometimes say, there's a lat tear, but it's primarily it's a muscle tendon injury. It's not the tendon off a bone, but it's the muscle separating from the tendon. I'm suspicious that in fact that what they have is a teres major tear and not a complete latissimus tear. So that's one thing to keep in mind. If there's a big muscle component to it, people have to remember the last 3 inches of the latissimus is just a very thin sheet of a tendon. And so if there's a big muscle component, most likely a teres major is involved. When we go to surgically repair those, my preference is to go ahead and repair that all at once. I don't try to say, well, we're just going to repair the lat. They are very close to where they insert on the bone, and we have strategies in terms of surgical fixation where we can incorporate both of those down to the arm bone of the humerus in a way that will get it back to its normal attachment site.
So that's fascinating. I think teres is an interest. I always refer to it as a mini lat, and what it really you take away is its ability to really effectively transfer force from the lower extremity to the upper extremity, where lat's running down to thoracolumbar fascia. I think in certain portions of the population actually has attachment on the ilium. It's crucial for taking everything that you're generating from the ground and getting it to the humerus. Teres major just for me is more along for the ride. So I feel a lot better about a teres injury than I do about a lat injury, just historically speaking, but I'm not sure you can ever separate them, as you implied.
I think you're right, probably for a pitcher. I can tell you I've had exactly, I know it sounds a little strange, but kite surfing, windsurfing, and other forms of being on the water, like wakeboarding, they cramp up. They can't keep going because their teres cramps up on them whenever they try to hold with force, and that's why they end up coming in. They said, well, it doesn't really bother me. It looks a little funny, but it doesn't really bother me. But I can't keep doing my sport because every time I try to do it, it cramps up on me. So I do think, like you say, it may be secondary to the lat for throwing, but there are some sports or power maneuvers where it can play an important role. And I think that's probably where it looks like with your body, it's a 90-90. I know it's not exactly that at the humeral scapular junction, but it looks like your arms are about 90 degrees to your thorax. The other interesting thing I point out, and I'm sure you know this and have understood it for a long time. I remember once presenting some time ago to a group of spine surgeons, and we talked about the lat. And they said, "What do you mean it's a shoulder? That's a back muscle. That's a core back muscle. The latissimus. Look at all the EMG studies and lifting activities. When you actually look at that muscle, that's what it's primarily wired to. So clearly, it is an important place where there's a transit of the forces from the lower body and core up and into the upper extremity."
Absolutely. So switching gears a little bit, you were an author alongside Dr. Arison, who you mentioned earlier, a 2019 study. It was called Performance and Return to Sport After Latissimus Dorsi and teres major tears Among Professional Baseball Pitchers. So, in your eyes, what were some of the key findings, in that particular publication that you think have the most important implications for both players and clinicians?
So for me, this boils down to the thing that we talked about earlier, that if you have a complete rupture, whether it's just a few centimeters or more than a few centimeters away from its normal attachment site, we found with current modern surgical treatment that the athletes were more likely to get back to the same level of performance that they were able to achieve before the injury occurred. Athletes did not have surgery. Many of them also returned back to sport, but frequently could not get back to the same level of performance. And what you'll see is a history of them coming back. They'll play, and then it gets hurt again, and then they have to go out again. And so they have this roller coaster ride, and then subsequently something else seems to go. Their elbow goes or something else because they try to protect this area. And we have a number of instances where we've seen that. But we also found that the athletes that were treated non-operatively with a type 1 or type 2 strain, where there was some tissue still attached, and they recovered and got back, were able to achieve levels similar to their performance. And that's why we have this watershed finding and recommendation. If it's partially detached but not completely off, it's certainly worth a full effort to try to see if we can treat these non-operatively. If it's completely off, you can treat them non-operatively, and they will oftentimes get back. However, it'll be very difficult to get back to the same level for most of them. And so that was really the key findings that was supported by the work that we've been doing over the last 10 years on this topic.
I love that. So one interesting thing I noted just as I kind of went through that study, and in comparison to a few previous ones that I think were based on smaller sample sizes, as this injury wasn't as common, it seemed like the time to return to previous level of competition has increased. So it's taken longer for players to get back. I'm not sure if you've noticed this, and if so, do you think it's a function of us just having, better sample sizes to work with, and we now know what works best, or are we realizing that, taking our time is that much more important with both, conservative and surgery cases?
So I think the second comment is absolutely true. I think we've learned that these are not oftentimes a small strain that you can just bounce back quickly from. And so we've learned to take a little bit more time, and we hope that, particularly with the type 1 and 2 strains, that will actually allow a healing process that can be very good and let the pitcher and athlete get back to the same level. I also think that the reason why it's taking a little longer just overall is because we're seeing more of the type 2s and type 3s than before, because of our earlier discussion about the size of the athlete, the power of the athlete, the desire for velocity. And this is combined to see less and less of just a strain of the fibers with a little fluid, but actually some partial tearing or even complete tearing. And so those do take longer to get better. It can be highly variable. Some of the athletes get back pretty quickly, but a number of really, really talented baseball pitchers, it wouldn't be unreasonable to take anywhere from 6 to 12 weeks to be able to get back to the same level of performance. And so I really would go slow with this one if you have a type 2, and treat the athlete based on their symptoms and allow them to take the time that they need and not try to rush this. It'll give them the best chance of being able to avoid surgery and get back to the same level of performance.
Interesting. Looking at these studies as well, is there does seem to be like a large standard deviation in the return to play timelines. And actually talked to Dr. Dugas recently, where he kind of spoke to, there's almost like 6 to 8 week window on both ends for Tommy John repairs, where some, athletes will move faster, some will need to take more time. So I'm sure, similar things are in play when we're talking about surgical management of these type of injuries. What factors in your mind influence these individual outcomes? And with the surgery cases, does the time from the initial injury to the actual repair influence the outcome with respect to, how far the tendon has retracted?
So the first question, just in terms of, why is there so much of a standard deviation? I think that's we've classified it into sort of 4 categories, but we probably could divide those up a little bit more and include a better understanding of what we've talked about earlier when the teres major is also involved. So not just latissimus of the teres major. Because I think what happens with most of the isolated lat tears, and part of the reason why they don't come completely off, is when you go do an anatomy dissection or a surgical dissection, you see multiple little fibrous attachments between the teres major and the latissimus. They're in some athletes, they're fairly well integrated. And so, in fact, it's interesting because one of the challenges can be when you go in there a little bit late, those fibrous attachments are there, but the latissimus is short. And you have to separate those to be able to get the latissimus back to where it belongs on the humerus. So I think that some people really have a lot of interconnections between the teres major and the latissimus. So it works almost as a singular unit in some ways. And so when part of it tears, it has more of a support structure to hold it from going too far and allowing it to heal back into place. And I think that's one of the things that gives us some standard deviation. I think the second thing is as you know, it's hard to understand, but some athletes are just built differently than other athletes. And someone will have a tear of this and it'll be a type 2 tear, and it's fairly remarkable. And I'm not kidding you that, it happened like the week before. So they're sending them to me, and it takes a week to get everything coordinated. By the time I see them, they're almost asymptomatic. And then I say, okay, well, we just want to treat them non-operatively. And they're back throwing pretty hard within 4 to 6 weeks. Mm-hmm. And they have an injury that I've seen people would take 3 months or longer to get better from. And why is that the case? We don't know yet. And it's just some people are just wired differently and maybe are able to compensate and, believe it or not, on a subconscious level, adjust their pitching mechanism to the point that they use their other muscles to decelerate the arm, and it doesn't seem to require as much of their latissimus to do that. So I think those are the things that I suspect is part of the standard deviation, and that's why I like the classification based on the anatomy, and then the treatment based on the clinical response to how they're doing with the treatment we're giving them.
This was absolutely fantastic. I'm sure our listeners picked up a lot from this, and I certainly did as well, because I've taken some deep dives on this, and it's actually really great to see how you view it in terms of classifications and unique challenges with what is a unique injury. We haven't seen this for much longer than a decade, so it's awesome to have you at the forefront and being willing to share your knowledge. Folks can find you. It's Anthony Romeo, MD. .com, based in the Chicago area. And I'm also going to give a quick thumbs up. Along with our mutual friend, Dr. Chris Ahmad, you published a great book, Baseball Sports Medicine. It's one of those ones where you could read a chapter a day and just keep going back to it, because there's so many great pearls of wisdom for anybody that manages baseball athletes. So I definitely encourage all of our listeners to check that out. So Dr. Romeo, thanks so much for taking the time and to spend sometimes, sharing your expertise with us and bringing us up to speed on, what unfortunately has become a big part of the baseball injury landscape, but hopefully everybody's more well-equipped to manage this moving forward.
Eric, thank you for the opportunity. And to all those of you out there dealing with this, just realize we're much better than we were 10, 11 years ago. We understand the problem. We have a good algorithm for treatment. And so I think our athletes are in a better position to be able to get back onto the mound or get onto the field with the proper treatment. So the continued work of people like Eric and Major League Baseball, their research committee, Chris Ahmad and others, has really helped us keep our athletes healthy, and when they get injured, provide them with the best care possible. So Eric, thanks so much for the opportunity to discuss this topic.
This is great. Thanks so much.
Thank you for joining us for another episode of the CSP Elite Baseball Development Podcast. If you enjoyed this episode, we'd be thrilled if you'd consider subscribing to the podcast and leaving us a review to read on iTunes. We welcome your suggestions for future guests and questions. Just email elitebaseballpodcast@gmail.com. Thank you for your continued support, and we'll see you next episode.